This chart shows what the medical community observed for decades regarding alcohol and heart health. It maps out a classic J-shaped curve, illustrating an epidemiological consensus that the relationship between alcohol consumption and cardiovascular disease is not strictly linear. Looking at this pronounced dip in the curve, observational data suggested a clear benefit. Moderate consumers who drank 1 to 2 alcoholic beverages per day appeared to have a 22% lower risk of myocardial infarction compared to strict abstainers. To understand the boundaries of this perceived cardioprotective zone, we have to define the dose. In the United States, a standard drink is universally quantified as exactly 14 grams of pure ethanol, roughly the amount in a typical glass of wine or regular beer. This specific metric anchored public health guidance for years. Doctors frequently advised patients that incorporating a daily drink into their routine was an evidence-based strategy for maintaining heart health and preventing ischemic strokes. However, recent advances in genetic epidemiology have complicated this narrative. Newer data suggests that the heart-healthy benefits identified in these studies were likely the result of systematic errors in how the research was conducted. The medical community is currently undergoing a massive correction. Moving away from the endorsement of moderate drinking requires a total reevaluation of how we measure cardiovascular risk and what we consider to be a healthy baseline. The belief in the J-curve was historically supported by the French paradox. This was an epidemiological observation that certain European populations consuming significant amounts of red wine had lower mortality rates despite eating diets high in saturated fats. This diagram shows the core biochemistry of ethanol metabolism, a two-step enzymatic process in the liver. First, the enzyme alcohol dehydrogenase, or ADH, converts ethanol into a highly toxic compound called acetaldehyde. Next, aldehyde dehydrogenase, or ALDH, converts that toxin into a relatively benign substance called acetate. This metabolic process directly alters the cellular redox state. The conversion of ethanol and acetaldehyde reduces nicotinamide adenine dinucleotide, or NAD+, into NADH. This increases the NADH to NAD+ ratio, which suppresses gluconeogenesis and shifts hepatic metabolism toward fat synthesis. Despite this cellular stress, researchers did observe genuinely favorable biomarker shifts in moderate drinkers. Most notably, ethanol increases the production of high-density lipoprotein, or HDL cholesterol, and apolipoprotein A1, which helps transport fats through the bloodstream. Alcohol also exhibits some distinct antithrombotic properties. It actively lowers levels of fibrinogen, a protein essential for blood clot formation, and reduces overall platelet reactivity, creating a biological rationale for how it might prevent ischemic strokes. While ethanol does induce these favorable shifts in certain blood biomarkers, assuming these chemical changes automatically result in structural arterial health is a significant diagnostic flaw. The structural flaw in the older research lies in how the data was collected. Traditional prospective cohort studies suffer from endemic statistical biases that warp risk assessment and artificially manufacture the appearance of health benefits. The primary culprit is sick quitter bias. Grouping lifelong abstainers with sick former drinkers artificially spikes the abstainer's baseline mortality risk. The second distortion is healthy user bias. Moderate drinking is often a proxy for higher socioeconomic status, exercise, and healthier diets. Further compounding these errors is the issue of self-reporting. Populations consistently underestimate and underreport their actual ethanol intake, causing researchers to misclassify heavy drinkers as moderate ones. Once epidemiological data is rigorously scrubbed of sick quitters and healthy users, the protective dip for moderate drinkers evaporates. We can now see that the J-curve was a statistical illusion, born from a flawed comparison. To bypass these observational confounders, modern researchers turned to Mendelian randomization. Mendelian randomization is a genetic epidemiology tool, using inherited variants to predict lifelong exposure to a risk factor, acting as nature's own randomized control trial. Researchers use specific genetic variants, like the ADH1B and ALDH2 alleles, to predict lifelong alcohol exposure. Carriers of ALDH2*2 experience toxic acetaldehyde accumulation when drinking. This genetic intolerance naturally restricts consumption, getting researchers a clean, isolated control group. The findings from Mendelian randomization studies are definitive. When genetic predisposition is isolated from lifestyle factors, the risk for coronary artery disease and hypertension increases linearly with any amount of alcohol consumed. Genetic data proves that the cardioprotective benefits seen in older studies are non-causal artifacts. Human biology has no baseline requirement for ethanol to maintain cardiovascular health. Moving past statistical epidemiology, we have to look directly at the pathophysiology to track ethanol's physical impact on the heart and brain. The lipid paradox dissolves when we look at arterial imaging. The increased HDL cholesterol from alcohol does not translate to lower carotid intima media thickness, or CIMT. CIMT is a measurement of the inner layers of the artery that supplies blood to the brain, and alcohol provides no measurable reduction in its thickness or in arterial calcium scores. Instead, alcohol acts as a potent pro-arrhythmic agent. It acutely alters the effective refractory period in the atria, leaving the heart susceptible to chaotic rhythms. This period is the necessary recovery time a heart cell requires before transmitting another electrical impulse. Alcohol severely shortens it. Long-term consumption creates severe chronic electrophysiological impacts. It leads to left atrial enlargement and fibrotic low-voltage zones that permanently anchor atrial fibrillation, a quivering or irregular heartbeat that can easily lead to blood clots and heart failure. The arithmetic on this arrhythmia risk is clear. Meta-analyses show a 6 to 8% linear increase in atrial fibrillation risk for every single additional standard drink consumed per day. This diagram illustrates the cerebrovascular dichotomy of alcohol. Any minor antithrombotic benefits it provides for ischemic stroke are violently counteracted by the severe risks of hemorrhagic stroke. Binge drinking induces transient but incredibly sharp spikes in blood pressure. These acute spikes impair primary hemostasis and serve as a primary trigger for acute intracerebral hemorrhage. Alcohol acts as a dose-dependent systemic toxin. Any theoretical reduction in clot formation is aggressively neutralized by structural fibrosis and ruptured vasculature. At the most extreme end of consumption, chronic heavy drinking, exceeding 80 grams of ethanol per day, triggers alcoholic cardiomyopathy. Alcoholic cardiomyopathy is a severe condition where the heart muscle dilates, weakens, and fails to pump blood efficiently. This damage is driven by the direct toxicity of acetaldehyde. It induces severe oxidative stress, impairs protein synthesis, and triggers mitochondrial dysfunction inside cardiomyocytes. Chronic alcohol use also inappropriately activates the renin-angiotensin system, a hormone system that regulates blood pressure. Overactivation here promotes further myocardial fibrosis and detrimental structural remodeling of the heart. Yet, there is a defining clinical characteristic that separates alcoholic cardiomyopathy from idiopathic cardiomyopathies: its profound potential for reversibility. Absolute abstinence from alcohol allows for significant clinical recovery of the left ventricular ejection fraction, which is the percentage of blood leaving the heart each time it contracts. Even after enduring extreme toxic structural remodeling, the cardiovascular system retains a profound capacity to heal itself, provided the chemical trigger is completely removed. Expanding the perspective beyond isolated cardiovascular metrics to global all-cause mortality, the 2021 Global Burden of Disease Study makes the macro risk impossible to ignore. The reality underlying all consumption is that the International Agency for Research on Cancer classifies alcohol definitively as a Group 1 carcinogen. Here, we see the true risk assessment. Any marginal, heavily debated cardiovascular benefit from a daily drink is mathematically overwhelmed by the lifelong, cumulative risk of developing breast, liver, and esophageal cancers. This data has triggered a shift in global health guidelines. In 2024, the World Health Organization issued a clear declaration that no level of alcohol consumption is completely safe for human health. The American Heart Association has harmonized its stance with this data as well. Their formal recommendation states that if you do not currently drink alcohol, there is zero evidence-based reason to start for the sake of your heart. Furthermore, the American College of Cardiology now formally recognizes reducing alcohol intake as a primary, effective medical treatment for high blood pressure. The era of prescribing a daily glass of wine has ended. Modern clinical science identifies alcohol